Bismillahirrahmanirrahim. In today's lecture, I will discuss spirometry. Before spirometry, let's discuss some important terminology related with the spirometry. These are pulmonary volumes and capacities. Descriptions of these volumes and capacities. Lung volumes are also known as respiratory volumes. It refers to the volume of gases in the lung at any given time during the respiratory cycle. Lung capacities are derived from summation of different lung volume. When different lung volumes are added together, it gives us the lung capacities. The average total lung capacity of an adult human male is about 6 liters. Maximum capacity of human lung is 6 liters. Lung volumes measurement is an integral part of pulmonary function test. These volumes tend to vary depending on the depth of respiration, gender, age, body composition, and in certain respiratory diseases. A number of the lung volume can be measured by spirometry. The earliest attempt to measure lung volume. The earliest attempt to measure lung volume can be dated back to the period AD 129 to 200. Claudius Galen, a Roman physician, surgeon, and philosopher. Spirometry. Spirometry is the most common type of pulmonary function or breathing test. The test measures how much air a person can breathe in and out of lung, as well as how easily and fast a person can blow the air in and out of his lung. This can help diagnose problems like asthma and COPD, chronic obstructive pulmonary disease, or can be done to check lung function before a surgery. Spirometry is also done before treating for a chronic lung disease such as COPD, asthma, or pulmonary fibrosis. To determine if disease is improving or worsening and whether medication or inhaler are working properly. Spirometry can be done in doctor's office or in specialized pulmonary function test laboratories. Preparation before spirometry. On the day of test, stop certain inhaler or medication like steroid and bronchodilators. Wear loose clothing and avoid big meals before testing. These tests are not painful, they are performed by pulmonary function technician. The tests are repeated several times to make sure the results are accurate. When performing the test, keep the following in mind. Do not smoke for at least 6 hours prior to testing. A short-acting inhaler that is used only as needed. Do not use for 6 to 8 hours prior to testing if possible. During the test, you will be sitting in upright position. A clip is placed on patient subject nose and give a plastic mouthpiece connected to the spirometry machine. You will place your lip tightly around the mouthpiece and ask to take as deep a breath as possible and then hold the breath. See in this animation, take a deep breath and then hold. Place your lip tightly around the mouthpiece and blow out as hard as faster. Like this. Put the mouthpiece and then forcefully breathe out. Maximum effort is very important and testing will be repeated at least 3 times to get the best result. Spirometry. For studying pulmonary ventilation, what is pulmonary ventilation? The process of air flowing into the lung during inspiration or inhalation and out of the lung during expiration or exhalation. Is to record the volume movement of air into and out of the lung, a process called spirometry. Consists of a drum inverted over a chamber of water which the drum counterbalanced by a weight. This is a chamber which contains water and a drum which is invertedly put in this chamber and balanced by a weight. In the drum is a breathing gas. This drum is filled with a breathing gas or oxygen. A tube connecting the mouth with the gas chamber. This is a tube which is connected with the gas chamber and mouthpiece. When one breathes into and out of the chamber, the drum rise and fall, and an appropriate recording is made on a moving sheet of paper. When a person breathes, this drum goes up and down, and here is another drum which has a recording paper around it, and due to this upward and downward movement of the drum, this movement is recorded on a paper wall around the drum. Spirogram. A spirogram indicating change in lung volume under different condition of breathing. This is a spirogram and it indicates different condition during breathing, different change during breathing. Describe the event of pulmonary ventilation. The air in the lung has been subdivided in this diagram into 4 volume and 4 capacities, which are the average for a young adult man. In this graph we have 4 volume and 4 capacity. In the next slide we will discuss them in detail. Pulmonary volumes. For pulmonary lungs volume that when added together equal to the maximum volume to which the lung can be expanded. When these 4 volumes are added together, this is the maximum volume to which the lung can expand. The tidal volume. First volume is the tidal volume, is the volume of air inspire or expire with each normal breathing. Its amount to about 500 milliliter in the adult male. When we are normally breathing, the air we take in and the air we breathe out, this is called the tidal volume, and it is equal to 500 milliliter, and it is recorded in the spirogram in this pattern. In the center, this is the upward deflection is the inspiration and the downward deflection is noted by expiration. The inspiratory reserve volume. is the extra volume of air that can be inspired over and above the normal tidal volume when the person inspires with full force. It is usually equal to about 300 milliliter. As we are breathing normally, we breathe normally, and then after we breathe forcefully, like in this animation, you can see that when a person breathes forcefully, this appear in the spirogram in upward deflection, and it start from the inspiratory tidal volume, and it is equal to 300 milliliters. This is the maximum amount of air which a person can breathe after normal breathing, normal inspiration, and when he breathes forcefully and take the air inside the lung. This is the maximum amount which is equal to 300 milliliters. Expiratory reserve volume. The expiratory reserve volume is the maximum extra volume of air that can be expired by forceful expiration after the end of normal tidal expiration. This normal amount to be about 1100 milliliter. As I told you that during inspiration there is upward deflection in the graph, and during expiration there is downward deflection in the graph. After expiration, when a person forcefully expire, like in this animation, you can see there, when a person forcefully expire the air, a person is expiring forcefully the air outside the lung. So this appear in the spirogram in downward deflection after the normal expiration or the normal tidal volume. This is equal to 1100 milliliter. The residual volume is the volume of air remaining in the lung after the most forceful expiration. This volume average about 1200 milliliter. You can see that this is the volume when a person forcefully expire, still the air remain in the lungs, and this is called the residual volume, and it is equal to 1200 milliliters. Pulmonary capacities. In describing event in pulmonary cycle, it is sometimes described to consider two or more of the volume together. Such combinations are called pulmonary capacity. When two or more volumes are added together, they are called pulmonary capacities. Important pulmonary capacity which can be described as follow. The inspiratory capacity equal to the tidal volume plus the inspiratory reserve volume. This is the amount of air, about 3500 milliliter. A person can breathe in beginning at the normal expiratory level and distending the lung to the maximum amount. Here this is the inspiratory capacity. Here first he take the tidal volume which is equal to 500 milliliter, and then he forcefully inspire the air inside the lung. So it is the tidal volume and the forceful inspiration which is equal to 3500 milliliter. This is called the inspiratory capacity. The tidal volume when these two volume, the tidal and the inspiratory reserve volume is added, it is equal to inspiratory capacity. The functional residual capacity equal the expiratory residual volume plus the residual volume. This is the amount of air that remain in the lung at the end of normal expiration, which is about 2300 milliliter. This is the functional residual volume which remain in the lung when a person normally expire. So there is a downward deflection and then he forcefully expires. Still in the lung the air remain. So this is called the functional residual volume. The functional residual capacity equal the expiratory residual volume. This is the expiratory residual volume when a person expires forcefully plus the residual volume and this volume when he expire and then the air remain in the lung after forceful expiration. This is called functional residual volume and it is equal to 2300 milliliter. This volume and this, they both are, when they are added, they are called the functional residual volume and is equal to 2300 milliliter. The vital capacity equal the inspiratory residual volume plus the tidal volume plus the expiratory residual volume. This is the maximum amount of air a person can expel from the lung after first filling the lung to their maximum extent and then expiring to the maximum extent, about 4600 milliliter. The tidal volume, the forcefully inspire volume, the vital capacity which is equal to the inspiratory residual volume. This is the inspiratory residual volume plus the expiratory residual volume, inspiratory and then the expiratory residual volume. This is the maximum amount of air a person can expel from the lung after first filling the lung to their maximum extent and the expiring to the maximum extent about 4600 milliliter. First a person breathe in forcefully and then he expire forcefully. So this volume is equal to the vital capacity and this is the maximum air which a person can expiring to the maximum extent. The total lung capacity is the maximum volume to which the lung can be expanded with the greatest possible effort, about 5800 milliliter. It is equal to the vital capacity plus the residual volume. When the vital capacity and the residual volume is added, it is equal to 5800 milliliter. This is the inspiratory volume, this is the expiratory volume and this is the residual volume. So when all these are added, this is equal to 5800 milliliter. Pulmonary volume in women. All pulmonary volume and capacities are about 20 to 25% less in women than men, and they are greater in large and athletic people than in small and asthenic people. Minute respiratory volume. The minute respiratory volume is the total amount of new air move into the respiratory passage each minute. This is equal to the tidal volume time, the respiratory rate per minute. The normal tidal volume is about 500 milliliter and the normal respiratory rate is about 12 breaths per minute. So when we multiply 500 by 12, 500 is the tidal volume and 12 is the number of breaths per minute, it comes to 6000 milliliters. Therefore, the minute respiratory volume average about 6 liters per minute. A person can live for a short period with a minute respiratory volume as low as 1.5 liter per minute and a respiratory rate of only 2 to 4 breaths per minute. The respiratory rate occasionally rises to 40 to 50 per minute and tidal volume can become as greater as the vital capacity, about 4600 milliliter in a young adult man. This can give a minute respiratory volume greater than 200 liter per minute or more than 30 times normal. Most people cannot sustain more than one half to two-thirds this volume bar. Alveolar ventilation. The ultimate importance of pulmonary ventilation is to continually renew the air in the gas exchange area of the lung, where air is in close proximity to the pulmonary blood. These areas include the alveoli, alveolar sac, alveolar duct, and respiratory bronchioles. The rate at which new air reaches these areas is called alveolar ventilation. Dead spaces. Some of the air a person breathes never reach the gas exchange area, but simply fill respiratory passages where gas exchange does not occur, such as nose, pharynx, and trachea. This area is dead space air because it is not useful for gas exchange. On expiration, the air in the dead space is expired first before any of the air from the alveoli reach the atmosphere. Therefore, the dead space is disadvantageous for removing the expiratory gases from the lungs. So thank you. Please subscribe the channel and on the bell icon write down your valuable comment for improvement of the channel.